Good morning, everyone, and welcome to today's Grand Rounds. A couple of points of administration. We would ask that you please submit your questions through the Q&A feature, not via the chat, and we will have a Q&A session at the end of the presentation. At that time, we'll also be answering live questions. So if you would like to ask your question live, just use the hands up feature and you can be unmuted by the moderator. And if you're having any technical difficulties at all throughout the presentation, please just use the chat feature and we'll try and troubleshoot that with you. So it is my great pleasure to welcome my colleague, Dr. Luciano Sposato, today as our guest speaker for these rounds. Dr. Sposato is from Buenos Aires, Argentina, where he earned his MD from the University of Buenos Aires and served as chief resident from both in internal medicine and neurology prior to establishing his research program here at the Western University in London, Ontario. He is currently professor of neurology and head of the stroke program at Western in the Department of Clinical Neurological Sciences and holds cross appointments in the departments of epidemiology and biostatistics and also anatomy and cell biology. So he's a very active stroke neurologist and clinical researcher who directs the Heart and Brain Lab at Western University and holds the inaugural chair, the Kathleen and Henry Barnett Chair in Stroke Research. So Dr. Sposato's research focuses on the brain-heart connection, and his work has truly been formative in this area, with multiple seminal contributions describing the clinical and pathophysiological concepts of neurogenic cardiac injury, and specifically atrial fibrillation detected after stroke, and the pathological processes that lead to cardiovascular complications in stroke patients, which is sometimes termed stroke-induced heart injury. His work also spans associations between stroke and dementia, and has really inspired the inception of this renewed focus on interdisciplinary programs in heart and brain research, including my own. He has published over 150 papers in stroke and neurocardiology, and is a member of the editorial boards of both Neurology and JAHA, and also serves as the editor of the neurocardiology section of Stroke, which is the American Heart Association journal. So with that, Dr. Sposato's work has had real international impact. He's lectured nationally and internationally in over 300 conferences in 43 countries, and currently is the inaugural chair of the World Stroke Association Brain and Heart Task Force. So we are really truly honored to have such a leader in the field here with us today, and we look forward to hearing about his work. Dr. Sposato.
Morning, everyone. Thanks, Jody, for a very kind introduction. I was telling everyone that I can't believe that I'm presenting at the Ottawa Heart Institute rounds. It's an honor that I never imagined I would have been able to leave. Let's see if I can share my screen. Here. As you know, I'm a stroke neurologist, and I have, before I trained as a neurologist, I wanted to be a cardiologist, but it was actually, I thought it was too difficult for me. So I decided to be a neurologist, and that's how I have interest in both fields. I hope you can you see my screen there? Yeah, perfect, awesome. So the topic that I want to talk about today is atrial fibrillation detected after stroke, and you will see that it seems to be something rather simple, but when you get into it, it looks more complicated. So these are my disclosures, and in terms of the agenda, I will try to define what AFDAS means, or atrial fibrillation detected after stroke. Then I will show you some differences between this specific type of AFib and no AFib in terms of prognosis and outcomes. And then perhaps the most interesting part is comparing what AFDAS means in terms of risk of stroke or stroke recurrence compared to the AF that we know before stroke occurrence. And finally, what are the diagnostic and therapeutic implications of this specific type of atrial fibrillation? So in terms of definition, I think some of you might be familiar with Dr. René Favaloro. He was a rural doctor in Argentina. He trained as a cardiovascular surgeon, and he then went to the Cleveland Clinic, where he developed one of the, or I would say the first successful CABG surgery with a venous graft And since then, there have been around 1 million CABG surgeries per year done globally, thanks to the technique that he developed. If you go to the Cleveland airport, you will see pictures of René Favaloro there because of his achievements. So he came back to Argentina, and then he developed a hospital and a university. And the hospital is the Favaloro Foundation University Hospital. It was mainly a cardiology institute, but in 2005, they decided to create a neurosciences program, and I was invited to develop the stroke program at Favaloro Foundation University Hospital, which is the one that you can see here. So the first thing I noted when I was there is that they had a telemetry system. Before that, I had trained in hospitals with not a lot of technology. So I was amazed that I was able to monitor patients' heart rates or rhythms from the very beginning of their admission to the last day in which they were discharged. So because I was very interested in research, I thought maybe we should look at what happens with patients' hearts. And that was around 2007, 2008. So we started looking at the rhythm of these patients, and we found that the majority of the AFib episodes or paroxysms occurred within the first 3 days after admission, and then they tended to disappear, meaning that there was a clear relationship in terms of those episodes of AFib in terms of the occurrence of the stroke. And the other thing that we noted at that time was that patients were fairly young, and they didn't have a lot of structural heart disease. So that was quite surprising, and we thought it was worth communicating that in a publication. So that was I would say, a very rudimentary publication. It's just an observational study, but it opened my eyes to a different, perhaps a different type of arrhythmia. So we kept looking, and we found that these patients that we started calling among ourselves AFDAS, or atrial fibrillation detected after stroke, had a much more frequent involvement of the insular cortex. And as you know, the insular cortex is key in the autonomic regulation of heart rhythm and other cardiac functions. So we thought maybe some of these patients are having I'm sorry for that, are having less cardiac arrhythmias, are having cardiac arrhythmias just because of autonomic dysregulation of heart rhythm. And then we actually looked at structural changes in their hearts, and we found that the proportion of patients with a dilated left atrium or decreased left ventricular ejection fraction was similar between AFDAS and patients with no AF, but it was much higher in patients with known AF. So again, this told us that maybe we should separate heart rhythms in stroke patients and start looking at these types of rhythms to see if there were any meaningful differences. And that's when we came up with, many years later, we decided that it was worth publishing or showing that these rhythms were different. So just as a concept, patients with known AF, when they have a stroke, they usually don't have cardiac monitoring, and we know that AF was pre-existing, so we call it CAF or known AF. And then for patients with ischemic strokes or TIAs who do not have a history of AF, the standard of care is it's doing at least 24 to 48 hours of cardiac monitoring. And if we suspect that it's a cardioembolic stroke, we always do more than that, at least 14 days, 28, or sometimes more. And after that cardiac monitoring, we do not find the AFib in most of the patients. And in some of them, we do find that they have a newly diagnosed atrial fibrillation that we call AFib detected after stroke. So in 2014, there were two very important randomized controlled trials in Embrace from Canada and Crystal AF, which was more international. And they found that by applying prolonged cardiac monitoring, we were able to detect significantly higher numbers of atrial fibrillation in patients with stroke. So as soon as that was published, we performed a meta-analysis and we developed a Markov model based on the results of 50 studies that were included in meta-analysis. And we found that overall, among stroke patients, 20% of them have a known atrial fibrillation. That means that, that we're left with 80% of patients in whom, if we apply cardiac monitoring, we will find AFib in about 24% of them, which represents 19% of the overall stroke population. So we can safely say that 4 every 10 patients with stroke will end up having AFib, and it depends on how much we look for it. We may miss up to 20% of the cases if we don't perform cardiac monitoring, but we may be able to find 20% more if we do it. So this has very important implications in terms of epidemiology, because it means that 1.3 to 1.5 million patients are newly diagnosed with AFDAS or atrial fibrillation detected after stroke each year globally. So this is a huge number of patients that today we don't know exactly what to do. In general, we use anticoagulants for these patients, but I'll show you a little bit later that that might not be, and against all we know, it might not be the ideal treatment. So, and why am I saying this? So this is what happens to us, the neurologist, when someone comes with a stroke. This is a patient who had a stroke this day. And if we apply cardiac monitoring that you can see here, it's the gray bar, we may find a high burden of AFib, which is represented by the blue lines here. We might find just a burst of AFib immediately after a stroke, or we may find some isolated episodes a few weeks or months after a stroke. And this is the only thing we know, right? And these are real patients from the ASSERT trial. But when we look back, if we were able to look back in time and see if they actually had AFib before the stroke or not, we might see that some of them do have AFib. As you can see here, this patient had quite a high burden AFib before the stroke, but some of them never had atrial fibrillation detected after stroke. So this is the actual reality that we face as stroke neurologists. So we thought in 2017 that the terms were being used for I mean, in publications about atrial fibrillation detected after stroke were inaccurate. So, for example, people were using post-stroke AF, which, as I showed you before, might not be the reality, because some of these patients did have AFib before the stroke, but they didn't know, or their doctors didn't know. So post-stroke AF does not represent the reality of the AFib that we detect after stroke. Occult AF or silent AF or covert AF might not be real, because some of these patients do develop their AFib after the stroke and did not have AFib before the stroke. And we also know that subclinical AF should not be used for patients who had a stroke, even if they didn't have any symptoms before the stroke or AFib-related symptoms, because as soon as they have the stroke, it is not subclinical anymore. And this is a position statement from the American Heart Association. In terms of newly diagnosed AF, it's partially correct, but it does not reflect that it happened in patients with stroke. So it means that it can be somehow misleading, because it can also be a new AF that was diagnosed in the general population or other populations, such as patients with sepsis. And then we have paroxysmal AFib, which has also been used for these patients, but it doesn't actually represent the reality, because some patients with stroke are diagnosed with chronic or permanent AF instead of paroxysmal. So none of these terms were representative of the population that we were studying. So we decided to come up with this term, which is atrial fibrillation detected after stroke, or TIA, in which we are just defining patients who had an AFib that was detected after a stroke. That can be either paroxysmal or permanent, and can be prevalent, meaning that it existed before the stroke, or incident, meaning that it's a truly new onset atrial fibrillation. So once we had the definition, we wanted to know if this was really a new concept of arrhythmia, or if it was something that we were just making up. So we performed a systematic review and meta-analysis to look at what was the risk of stroke recurrence in patients with atrial fibrillation detected after stroke compared to sinus rhythm. You can see here These are the number of studies, and we found in general that AFDAS has double the risk of stroke compared to patients with sinus rhythm or no AF, that these patients have a higher risk of death, 60% higher risk of death, and that they have 74% increased risk of dementia. This is just one study from Ontario that we did a few years ago, in which we looked specifically at the population with stroke, and we compared AFDAS against patients with sinus rhythm, and we found 74% increased risk. But I want to show you something here, going back to the increased risk of stroke. I'm going to get into this meta-analysis. We have 1, 2, 3, 4, 5 studies showing that the risk of recurrent stroke in patients with AFDAS is at least twice higher than for patients with no stroke. But this is our own study here, again, performed among the population of Ontario. And this is the only one that really adjusted the risk for the use of oral anticoagulants and other risk factors, and I'll show you here. So this is the time after stroke onset, or actually the discharge in patients who survived their stroke. And this is the risk of stroke recurrence in patients with AFDAS. You can see here quite lower risk than for patients with sinus rhythm or no stroke, or AFib known before the stroke. But these are unadjusted results. We did perform 3 different models in which we included quite a number of variables. This is an ICES study, and we showed that, or at least we found that there were no differences in terms of the risk of stroke recurrence in patients with AFDAS compared to patients who were never diagnosed with atrial fibrillation. And what we did find is that, as expected, patients with known AF before the stroke did have a higher risk of stroke compared to no AF. One thing that I have to clarify here is that these patients were diagnosed with AFDAS during admission, meaning that it was probably diagnosed during telemetry or maybe with the admission ECG, meaning that this specific type of AFDAS in this study is I would say, relatively high burden, and as such, relatively high risk. So what happens when we compare AFDAS with known AF? And I think this is perhaps one of the most interesting aspects of this topic. So again, we performed another meta-analysis in which we looked at over 54,000 articles. We ended up finding 21 papers to be included. And what you're seeing here is a summary of the paper, which shows a single meta-analysis for each of the variables that are shown here, in which we compared AFDAS versus CAF or known AF. So for example, we did not find any differences between studies in terms of age and sex in AFDAS versus CAF, but we did find that there was a 21% lower prevalence of hypertension in patients with AFDAS, and 18% lower prevalence of dyslipidemia in patients with AFDAS as well. More interestingly, in terms of vascular comorbidities, patients with AFDAS seem to be much healthier because they had a lower history or a lower prevalence of CAD or coronary artery disease, prior myocardial infarction, heart failure, peripheral artery disease, or even a prior stroke. And in terms of structural changes, patients with AFDAS had a higher left ventricular ejection fraction by 25%, and a striking 65% lower prevalence of left atrial enlargement. So, or I would say more correctly, 65% smaller left atrial area. And there were only 2 publications showing an association with the insular cortex, and we were not able to perform a meta-analysis because we have pre-specified that we would need at least 3 publications for a single meta-analysis. So when looking at this picture with all these variables together, we thought, if patients with AFDAS have a lower prevalence of risk factors, vascular comorbidities, and they have a higher or a healthier heart than patients with CAF, the outcomes of these patients should be better as well. So we looked at the CHESVA score, and we found that overall it was 47% lower in patients with aphthous compared to CAF. And interestingly, there was a 25% lower recurrence rate in patients with aphthous and CAF, meaning that these patients do have, or seem to have, of course, this is just a meta-analysis, they seem to have a lower risk of stroke compared to CAF. And you can see here, these are the 3 studies that we included in this meta-analysis, and they all show the same trends towards lower risk in patients with aphthous compared to CAF. So why are these patients lower risk, or why do they have a lower risk of stroke recurrence, and why do they seem to be healthier? And I think we have a few answers here. So you know that mostly in the US, patients who have a recent stroke undergo prolonged cardiac monitoring, meaning that they received implantable loop recorders in a fairly large proportion. And then, of course, based on clinical trials, we know that the use of prolonged cardiac monitoring, or ILRs, results in higher AFib detection rates. There's no question about that. There's no question that the higher detection of AFib also leads to more anticoagulation. But the interesting thing that we just found recently is that the use of implantable loop recorders and other prolonged cardiac monitoring strategies is not related to lower stroke recurrence rates. And here we have to clarify something. First of all, none of the clinical trials that I will show you here used stroke recurrence as a primary outcome. This was a secondary outcome, so it is possible that these trials are underpowered for finding a difference in terms of stroke recurrence. But if you see the confidence intervals here, they are pretty small. So that's something that I may question. But just to get into these results, let me explain you what this means here. So we performed a meta-analysis for recurrent ischemic stroke as a primary outcome. These are 4 clinical trials, and these are the number of patients, months of follow-up. And you can see here that by combining the results of these 4 clinical trials, we did not find an association between the use of prolonged cardiac monitoring and lower stroke recurrence rates. When we looked at other outcomes, such as ischemic stroke and TIA, or recurrent stroke of any type, or recurrent stroke of any type and TIA, we found similar results. So the conclusion of this slide is that to date, we do not have any evidence that using implantable loop recorders or other prolonged cardiac monitoring strategies are related to lower stroke recurrence rates. We detect more AFib, we use more anticoagulants, but that does not translate into fewer strokes during follow-up. So why is this happening? Why, by detecting more AFib in patients with stroke, we are not reducing the risk of stroke recurrence? And we have some clues here from the ASSERT trial. I think this is a great trial that if we look into it in more detail, will show you quite interesting results. So these are actual patients from ASSERT. You can see the gray bar here is a duration of monitoring. The vertical line is the day in which patients had their strokes. And the yellow lines here are the AFib burden or AFib paroxysms before the stroke. And you can see patients that have exclusively known AF before the stroke. They have high burden, they repeat. Some of them are related to the onset of the stroke, some of them are not. But when looking at patients with aphthous, we see very clearly that some of them occurred just immediately after the stroke, which means that this could be neurogenic mechanisms leading to the episode of AFib, and it does not repeat throughout the rest of the monitoring period. And then we have some isolated low burden paroxysms of AFib that might not have a causal relation with the stroke, right? These are patients that are just found to have AFib because they were wearing long-term monitoring devices such as ICDs or things like that, that may have some structural heart disease, but not necessarily a pre-existing atrial fibrillation. So just by looking at this picture, you can see that CAF is high burden and AFDAS is overall low burden and not related so closely to a stroke. So we thought this was quite interesting. So we performed another meta-analysis, and we looked at the number or the proportion of AFib episodes lasting less than 30 seconds in patients with stroke that were monitored for long periods in observational studies and clinical trials. So I know most of the audience here are cardiologists, and we are all aware that less than 30 seconds of AFib, it's not AFib, but I just want to remind everyone that this is quite a consensus definition that was made many years ago by a few cardiologists that thought that less than 30 seconds was very difficult to determine if it was AFib or not. So we all use more than 30 seconds. But there are a few studies, the ones that you can see here, that reported both less than 30 seconds episodes and more than 30 seconds duration episodes. And we compare the proportion of those episodes in patients with stroke, and overall, 52% of them were shorter than 30 seconds in duration. So that means, or at least confirms what I showed you before in the previous slide, that AFDAS seems to be a fairly low burden arrhythmia, and that may explain why patients with stroke and newly diagnosed AFib do not have such high recurrence of stroke. Okay, so this is a very interesting paper by Jason Andrade and his team. I really like this paper because they were very nicely showed that the more we monitor patients, these are patients who had an ablation, not necessarily with a previous stroke, and these are different monitoring strategies that they modeled, and they found that of course, by using implantable loop recorders, they could find more atrial fibrillation. But the interesting part here is these are patients who underwent different monitoring strategies. For example, 3 Holters of 1 day duration each, or 3 times 2 days, or 3 Holters for 7 days each. And these are the number of patients that could have been diagnosed by applying that strategy, right? The orange one, the purple one, green, and red. And the other ones, the difference between the blue and the other areas are the patients that were missed, that would have been missed by applying that strategy. And the interesting thing here is that those that were diagnosed with the shorter monitoring strategies had a much higher or larger burden of AFib than the ones that were missed. So again, this clearly shows that the more we monitor patients, higher detection rates we achieve, but at the end, we end up diagnosing very low burden types of AFib that might not be related to a higher risk of stroke. So we had the chance to write an editorial with Jason, and we proposed that by using, for example, an ECG, and if we find AFib with someone who's wearing an ECG, who had an ECG on admission, for example, that AFib is surely high burden. If we use external monitors for 14 days or 28 days, we might find AFib of lower burden, but not such low burden that it's that we can consider it low risk. And with implantable loop recorders, we might be finding AFibs that are not clinically meaningful, and that's the main problem that we're seeing in these days. So to put this into a more practical perspective, you can see patients who had strokes who are being just tested with ECGs or 14-day Holters or 3 years implantable loop recorders. These are different types of arrhythmias. For example, this is a patient who had CAF, and if he had an ECG on admission, we would be able to find AFib very easily. With a 14-day Holter, it would be easy as well. And with an implantable recorder, of course, we would find the AFib. If we have one of those neurogenic episodes in which we just see a short burst of AFib a few hours or maybe days after a stroke, we may miss it with an ECG if it's not done at the right moment. We might find it with a 14-day Holter, and of course, we'll find it with an implantable loop recorder. And if we have patients with those very isolated paroxysms of AFib, we would surely miss them with an ECG. We would miss them with a 14-day Holter, and we will find them with an implantable loop recorder. So if you see here, with an ECG, we usually find very high burden AFib, and you know this very well, even in patients without stroke. With 14-day Holters, it might be the right balance in terms of finding relatively high burden arrhythmias, but with implantable loop recorders, we're finding a very heterogeneous group of arrhythmias, which may not have the same meaning in terms of outcomes or prognostic implications. So these are the patients that we call AFDAs in general. These are the ones that may constitute a mix of high risk and low risk types of atrial fibrillation. So again, going back to this chart, we are with implantable recorders, we may have a very high sensitivity at the expense of perhaps a lower embolic risk. But of course, AFib burden is not the only determinant of stroke risk. We need to consider other factors such as the presence of a dilated left atrium or atrial cardiopathy in any of its definitions. So we should never consider the AFib burden itself and isolated from other variables, and we actually would need to combine them in a way that we can theoretically define an embolic threshold. And the embolic threshold means that perhaps for patients with relative low burden but a dilated left atrium, they are still at high risk of experiencing a stroke, but those who really don't have a high burden of AF and are below the embolic threshold, they may not benefit from oral anticoagulants and may need a close monitoring of their left atrial size or premature atrial complexes and things that will possibly progress to AFib within some years, but not necessarily require anticoagulation at the time of the diagnosis. And then for those patients who do have a high prevalence of atrial cardiopathy and who have high burden AFib, of course, they would benefit from OACs, and there's no question about it. So basically, we can stratify AFDAS or atrial fibrillation detected after stroke into I would say three main categories. One of them is the cardiogenic one, and just remember that we as neurologists, we ignore this history in most of the patients, right? So these are patients that if you see someone who comes with a stroke and has high burden AFib on their cardiac monitoring, these are patients that are likely that they likely had AFib before the stroke, and that AFDAS is very similar to a CAF or a known AFib, and as such, there's no question that they benefit from anticoagulants. Here we have tons of studies comparing warfarin and aspirin. We have Favaloro comparing apixaban against aspirin, and then we have more recent trials comparing DOACs against warfarin, and there's no question that those patients need to be on anticoagulants. But then we have two additional patterns of AFDAS. One of them is the one that happens just immediately after a stroke and could be neurogenic because of inflammation and because of acute atrial fibrosis that develops after the stroke. We have a rat model in which we injected endothelin-1 in the insular cortex of rats, and then we injected them another group of rats with saline, and we looked at the hearts of those rats at 7, 14, and 28 days. Of course, there were different rats, but we looked at the left atrium of those rats, and they develop a massive amount of fibrosis just after the stroke. And at 14 days, you can already see differences between between sham and stroke rats in terms of the proportion of atrial fibrosis, endothelial dysfunction, and infiltration of inflammatory cells in the left atrium. So it's clear that based on inflammatory changes and based on neurogenic dysregulation of heart rhythm, patients with stroke can develop neurogenic atrial fibrillation. And then we have another group of patients, which are the ones that are diagnosed with very isolated, low burden episodes of AFib that might not have any real clinical implications. These are patients that have AFib because they are monitored, and I'm pretty sure that by monitoring the whole world population, we would be able to see lots of episodes of benign atrial fibrillation. And I would say it's not a physiological kind of process, but it's a natural aging process that may not be related to a higher stroke risk as long as it behaves like this. So this is something I was very glad to see that the European guidelines on atrial fibrillation have embraced the concept of AFDAS, and they recognize for the first time, I think, in a clinical guideline that there might be some neurogenic arrhythmias, and these require further investigations. So to conclude, what I can tell you is that AFDAS is possibly a distinct clinical entity, which is the result of perhaps using prolonged cardiac monitoring. We wouldn't be able to find these differences if patients did not have or were not using implantable recorders or prolonged periods of cardiac monitoring. They seem to have an overall lower embolic stroke risk with lower prevalence of structural heart disease and vascular risk factors. So in terms of future research, I think the main question here is, how much do we need to monitor stroke patients to find a clinically meaningful atrial fibrillation? That's a great question that today we don't know. And then once we find AFib in stroke patients, which is a right combination of risk factors, structural heart disease, and burden of AFib that requires anticoagulation without exposing patients to an unnecessary risk of bleeding. This is something that may change in the future with the use of newer anticoagulants that are being tested, but so far today, we don't have a clear sweet spot for ECG monitoring. Well, thank you very much. I think this is all, and I would be very happy to chat now.
Well, thank you so much. That was an excellent presentation, Dr. Sposato. We're very, very excited to see your work. I just want to remind everyone, if you have any questions, you can enter them now into the chat, or you can do a live hand up. Oh, sorry, we have Peter. Go ahead.
Oh yeah, so Luciano, that's actually a fabulous presentation. So much new information, and no one will ever tell if you didn't tell people that you're not a cardiologist. And but it's just a fantastic presentation. So I guess sort of a comment and question. So one is that Jeff Healy has this trial, the Artesia trial, trying to look at the device detected atrial fibrillation, and with a PCM randomization. We are actually kind of attaching ourselves to that study, looking at the biomarkers, strategy to see if fact we can, sort of identify risk. But the question I have is that, it's fascinating that there are these, I guess, potentially calf-related, certainly it's an embolic type of a stroke versus the neurogenic stroke. So are there ways to distinguish these parts, let's say, from kind of atrial fibrillation burden, in which we kind of look at it, of course, so the AFDAS, sort of component versus the CAF component. Are there other ways to, sort of distinguish them, because it appears that, they are relatively distinct entities associated potentially with different pathophysiologies. Yeah, this is fascinating.
Thanks, Peter, for the nice comments. And that's a great question. And the short answer is no. We don't have a way of differentiating between those type of arrhythmias, except for the burden. But that's why we think we need a new clinical trial in which everyone should receive an implantable loop recorder. We should measure biomarkers, inflammatory panels, and see who develops AFib or in the long term, who develops strokes. So we're working on that, and hopefully we can collaborate in that project. And we need to characterize those arrhythmias better. So far, the only thing that we have is burden, and I think that's not enough.
Thank you, Rob. I'll just go. There's one question coming in on the Q&A, and I see your hand. We'll go to you right after. Dr. Hassan Mir just put into the Q&A, from a clinical perspective, is there a particular duration of AF that is short enough that you would start anticoagulation based on current evidence?
That's a super tough question, and we see that all the time, right? We see, for example, in London, we use 14-day Holters. And sometimes we see 11 seconds of AFib, and person reporting those AFibs are pretty sure that it is AFib, and then there's no question, right? So should we, if we have a patient with embolic strokes, multifocal, bilateral, cortical, and we find 11 seconds of AFib, it would be very difficult for us to not anticoagulate, right? It's clear. But if we have someone, for example, I had a patient, I had a PFO closure, and he developed AFib just a few days after the closure. It was 3 hours in a total of 14 days. And should we anticoagulate that patient? It is a different situation, right? But if we have someone who has a very deep infarct and there are 30 seconds of AFib, I'm not sure that we should anticoagulate those patients. What we are doing now is following clinical guidelines. So clinical guidelines very clearly state that a CHAS-VAS score of 2 or more should warrant anticoagulation. And patients with stroke have 2 points just because of the stroke, right? So far, there's no doubt that we should anticoagulate everyone, but we still need to look more and understand more which patients we need to anticoagulate.
Yeah, absolutely fascinating, Luciano. Thanks so much for coming. I wondered if there were, and you kind of alluded to this, to the example you're giving, if there were types of stroke, like where it's clearly an embolic phenomena, or the neurologist thinks it's definitely embolic, as opposed to other forms of stroke, where they think it could be related to athero or and so on. So does that help you in any way? So that's kind of my first question. The second question is, I mean, the CHAD score, as you pointed out, is, the stroke, it gets 2 points, so you're automatically anticoagulating people. So is it because AF detected in those studies was well after the stroke? Is that the problem? Is that the difference in your study and so on? And then I had a short question on the ASSERT, where you showed the known AF beforehand, but you didn't record AF afterwards. So I'm just curious, is that just the display, or was there actually no AF after the stroke? So
thanks, Rob, for the great question. I will try to remember them, but if I forget at the end, I'll ask you again. Yeah. So the first one was, if the type of stroke or if the stroke etiology would guide the use of anticoagulants in patients in whom we find AFib. So there's a huge controversy around that based on the Stroke AF trial, right? It showed around 14% AFib detection at 1 year in patients with carotid disease or small vessel disease. That's the etiology of the stroke. And that was exactly the same rate that they found in Crystal AF, which was based on cryptogenic strokes, meaning that both patients with apparently embolic strokes and with other mechanisms have exactly the same AFib detection rates. Mm-hmm. So based on that trial, there's a huge controversy because the PIs of that trial are suggesting that we should anticoagulate everyone, that it doesn't matter if it's the cause of the stroke or not. It's just AFib, right? But I think they are not, or they are neglecting all the data that I have just shown here, which suggests that not all AFibs are the same. So I do think that we need to understand a little bit more. If we find someone who has carotid disease and a new AFib, we will probably go for an endarterectomy and then use anticoagulants after an endarterectomy, because that's what we have been doing for years. But that's a totally open question to me. The second one was the CHASVA score, right? So most guidelines have moved from the CHAS score to the CHASVA score now to establish the risk of stroke. The problem with the CHASVA score is that it's very variable across populations. So you can have a CHASVA score of two in one population and you measure the risk of stroke, it's around 2.4%, and then another population, it could be as high as 8. So it's very unreliable, and we know that it doesn't predict. It's not ideal for predicting stroke, right? So that's number one. Number two is that all those studies and the way in which the CHASVA score was developed was based on patients with CAF exclusively, right? So very high risk AFib, which is not the same as the one that we diagnose after a stroke.
Is that true? I mean, because it was a history of stroke that makes you, like, isn't it stroke anteceding the detection of AF?
Well, it can be either ways, right? It could be that the stroke was detected before the AFib, but those are patients that usually have an AFib that is not detected on prolonged cardiac monitoring. That's what I'm trying to mean. It's patients that have an AFib detected on ECGs, which is high burden, as we all know.
Right.
Yeah. So I don't think there's, or at least I'm not aware of any studies on CHASVA scores or CHAS scores based on AFAS patients exclusively. And then the third one was
the display on the ASSERT trial of the known AF.
Oh yeah. So those are patients that did not have AFib after the stroke. These are, I just copied the picture on, I think it's a paper that was published in Stroke. Yeah.
Interesting. Okay, thanks.
No problem.
I have a question, but I'm going to just go to another one that's in the Q&A here. Dr. Kaylin Redpath asks, or indicates, an arrhythmia of 11 seconds is very difficult to characterize, especially on single or 3-channel recordings. So could overdiagnosing AF explain some of the low-risk AFDAS findings?
Absolutely. Yeah, I agree with that. It might be not an AFib, but yeah, 100%. Yeah.
My question now, if I can kind of jump in, you showed us this sort of schematic about this embolic threshold and these patients who have this very high burden and potential absence of other markers such as left atrial dilation. And I wondered, you indicated that those that don't exceed that threshold may kind of demonstrate a lack of benefit of oral anticoagulation for stroke recurrence. But I wondered if there may not be evidence around this, but your thoughts on whether or not there still may be benefit with respect to cognitive decline or dementia risk.
Yeah, absolutely. That's something that we need to look at. For example, we looked at the brains of around 1,000 people with Alzheimer's disease, and we that with Alzheimer's disease we can establish the severity of the degenerative changes in Bragg stages. Bragg and Bragg 1, 2, 3, 4. 3 and 4 are the more severe ones. And in patients with AFib, they had microinfarcts, and those with heart failure as well. Microinfarcts that lower the threshold for a clinical diagnosis of dementia, even if they were on Bragg and Bragg stages 1 and 2, which were the less severe ones. And those are silent microinfarcts that we're not aware of in patients with AFib. So that is total, and it's 5 times more frequent than clinically evident AFibs, strokes. So of course, that's something that we totally ignore, and it's a totally open field for investigation.
Okay, sorry, I was on mute. So Dr. Nair has put a question into the chat. At the moment, we are not calling 11 seconds irregular atrial rhythm AF. So are we underdiagnosing AF? Oh, I think you're on mute. Yeah.
Sorry for that. Yeah, I think that's a controversy. The people reading our Holters, if they don't see a P wave and if they see lots of premature atrial complexes and the rhythm is totally irregular in those 11 seconds, they call it AFib because these are stroke patients with embolic strokes. But it might be it might be under or over diagnosing AFib. I really don't know. And I don't know, you are a cardiologist, you know more than me, but sometimes even if it's not 30 seconds, it might be easier it's so clear that it's AFib because there are no P waves, it's an irregular rhythm. And sometimes it's a little bit more controversial. I think it has to be analyzed on a patient by patient basis, but I would like to hear from the cardiologists what they think about this.
I think Dr. Nair might want to respond. Girish, are you on? You're on mute if you're trying to respond. Your hand's up. Go ahead.
Yeah, can you hear me, Luciano?
Yes.
Yes, perfectly.
Hi, Luciano. Hey, it was a pleasure. It's a great talk. And, we are also part of the Canadian guidelines, and we struggle with this all the time. There's a lot of evidence suggesting that, a high burden of ectopy, non-sustained multifocal atrial tachycardias, which are less than 30 seconds, etc., are associated with an increasing trend or risk of embolic strokes. And we've been debating whether to me, it looks like a ROC curve, the sensitivity versus specificity, positive predictive value is negative value. And then I think you'll have to balance the risk of anticoagulating such patients. So, Artesia is looking at device-detected AF lasting a few hours. It'll be fascinating if, I know that there were a couple of trials which are planning to look at high burden atrial ectopy and non-sustained tachycardia and then anticoagulate them. What is your opinion on that? And clearly we'll have to balance the bleeding risk with stroke risk in these individuals. And, DOACs have improved our profile that way, but still they're not without risk. So what would you do? I mean, what is that sweet spot where you would initiate anti-tach, what burden of AF or non-sustained atrial tachycardia? Thanks. It's a long-winded question, but sorry about that.
No, it's very clear. Thanks so much for the question. It's fascinating because if we see a very high burden of ectopy without actual AFib, it might be higher risk that another patient with a low burden AFib and no ectopy at all, right? So both are conditions that we need to analyze in the context of the overall risk of the patient. So there's very, very strong evidence showing that increased ectopy is associated with higher risk of stroke. We just don't know which amount of ectopy requires anticoagulation, and if we can just use it for everyone who has a certain amount of ectopy, right? And so that's why I think those trials are needed. The only problem that I see with Artesia and NOAA are that they are not stroke patients exclusively, right? They are patients, but if they show that I don't know how much we can apply that to stroke patients themselves, but if they find that above a certain threshold, everyone has higher risk and may benefit from anticoagulants, that could be an answer for the question.
Yeah, and just as a quick follow-up to that, is there any role in looking at incidental cardiac imaging to see if there's a lot of atrial dilatation or remodeling? Does that, like we've seen the LAVI or the left atrial volume index correlate with occult stroke and stuff like that? So is there something that you're working on from that aspect for the heart brain thing?
Yeah, absolutely. The left atrial volume index or other measures of left atrial size, it's highly correlated with stroke risk, and sub-analysis of the ESUS trials have shown quite clearly, of course, these are just secondary analysis, that patients with increased or larger left atrium benefit from anticoagulants compared to aspirin, right? So those are very high risk patients that I really favor anticoagulating.
Okay, thank you. Oh, Peter, sorry, go ahead. You have your hand up.
Yeah, so if I can be indulged with a follow-up question, and this is, I think, so after looking at the ASSERT trial, looking at those, I guess, sort of cluster of AFib, in relation to the stroke event, and because there seemed to be time gap in that setting, and then the fact that there are other potential markers, whether it's burden of premature beats or the size of the atrium. Sometimes I wondered whether we can actually ask the question. I guess some of this is a little bit of controversial in that is atrial fib truly the cause of a lot of these stroke, or is atrial fib is just part of a kind of a set of marker of an underlying substrate? I know kind of Jody certainly thinks that way, so, it's really actually, we have a substrate, this convergence of risk factors, to potentially inflammation and, remodeling aspects, and possibly change in terms of the procoagulant state. And that atrial fibrillation is one set of manifestation, but, we may actually have others, and that, you can end up with the same kind of a clinical phenomenon of stroke, but in fact, they have different pathway. Right now, certainly, identifying AFib is the dominant approach. So, what's your thinking? What's your view on that?
Yeah, that's a great point, and it's a whole concept supporting the Arcadia trial, right? So patients, AFib might just be another biomarker of stroke risk in patients with underlying atrial cardiopathy. And we don't need to find AFib to anticoagulate some patients, right? So that's one view. The other view is that some patients develop AFib without atrial cardiopathy or without evident atrial cardiopathy based on the or the definition that we actually use, which is a dilated left atrium, increased BNP, or increased P wave terminal force in V1, right? So yeah, that's a very attractive concept. It would be very nice to see what happens with Arcadia and see if anticoagulants are beneficial in those patients. It's going to be ending soon, and hopefully we'll have results in the next couple of years.
All right, thank you so much. I don't have anything more here on the Q&A, but I'll just remind everyone who wants to join in half an hour's time. The roundtable will be beginning if you have additional follow-up discussion or questions for Dr. Sposato. So we will be doing that at that time. So again, thank you today for your time and for this lots of discussion generated from this conversation. I think we'll really be looking at the development of this area of research, because important implications for all of us.
Thank you very much, Jody, and everyone. And
thanks so much for coming, Luciano. Thanks a lot.
It's my great pleasure. Thank you. See you soon.